Okay, so my name's Kevin Hedges. I'm an occupational hygienist. I've got 31 years experience. I'm certified and I also have a doctorate. My doctorate's in research in North Queensland. So I just quickly wanted to talk about the hierarchy of prevention, control, banning, just thinking about the most important controls and also thinking about the gaps in long-term care homes. So the president of the CRBOH, Marc-Andre Lavoie, actually calls himself an occupational health scientist. And he seems to think that's a better way to describe our profession. And I agree with him. So we're the science people behind occupational health, but we really deal with exposures, and we deal with how to actually control the exposures and how to prevent, how to prevent illness. I really want to sort of talk about that related to long-term care homes. And it's really great to be part of this interdisciplinary group. We've got a really good cross-section of experts here. Thinking about the hierarchy of control, I've got it there, and there's lots of different things that we can do to reduce exposure. So it's really around the hierarchy of prevention. It's all the different components in that triangle that you see there. But I think when you look at this, what really is very important in the context of what we're looking at is there should be more emphasis on ventilation in long-term care facilities. And we need to have much stronger emphasis on respiratory protective equipment in long-term care facilities as well. And if you think about all the different levels of control, not one control is better than another. They're all important, but really the most important thing to do is to look at the source and try and eliminate the exposure at the source and then work your way down. But all of these layers have to be in place. And being the past president of Workplace Health Without Borders, I just finished a 3-year term. We had Dave Zorc present on Workplace Health Without Borders about control banning. So he's a very good, this is a very good YouTube video if you want to find out more about control banning. So it's really just a way of ranking the risks, if you like, and then figuring out what's important and where we really need to apply the critical controls. And that's just a matrix, a very busy matrix. It's really a risk communication tool. It's really, people say, well, I'm in this particular job type here. These are all the sort of controls that I need to have aligned with the hierarchy of control. Teresa Tam has actually now come out and admitted aerosol transmission, and WHO, the World Health Organization, have just acknowledged with their infection control guidance, and they talk about ventilation, which is a real phenomenal thing when you think about it. And also the Public Health Agency of Canada has just identified the importance of indoor ventilation during the pandemic. And this is kind of coincidental with a letter that was sent on the 6th of January. Okay, so there's a very good article in The Economist where they talked about Japan reducing infection using the 3 Cs. And also there's the Center for Disease Control has actually indicating that aerosol transmission is thought to be the main way of exposure. And if you think about long-term care homes, I've just tried to identify these controls and think about some gaps. And there's a study here where they've compared British Columbia with Ontario, and Ontario is doing a lot poorer, is poorer compared to British Columbia, and it's more to do with overcrowding in Ontario. There's a lot of debate at the moment about use of portable air cleaners. You might have seen in the press recently in Quebec that they're actually refusing the implementation of portable air cleaners. We believe that they work, and it's actually in our letter. So I've just put something in there about that. And respiratory protective equipment is really, really critical. So that's basically me. I've just included some interesting references on the last slide. So I'll hand it over to the next speaker. Thank you.
Good afternoon. My name is Raymond Tellier. I'm a physician and specialist in medical microbiology. I work at the McGill University Health Center, and I'm associate professor at the Department of Medicine of McGill University. I'm also an adjunct professor at the Department of Pathology and Laboratory Medicine at the University of Calgary. So I want to talk to you today about the modes of transmission of COVID and in a general manner for respiratory viruses. So other respiratory virus like SARS virus, influenza virus, you have basically three possible modes of transmission which are not mutually exclusive. Many of these viruses have more than one mode and probably all three. You have the so-called contact transmission, which can be direct or indirect through contaminate objects, which are called fomites, where you enter in contact with secretions and then it's followed by self-inoculation in your nasal mucosa or your eyes with contaminated hands. You can be infected by large droplets that fall quickly on the ground and which contain virus. And you can be infected by aerosol-sized droplets that are so small that they will remain suspended in the air for quite a while and may be carried away in the room, although they're getting diluted along the way. If you want to have an intuitive picture of aerosol and aerosol behavior, just think about the tobacco smoke from a smoker, from a cigarette smoker, where the volute of the smoke are aerosols and they tend to remain suspended in the air and they can get carried away, but you are exposed to more aerosol in close proximity to the smoker. So this slides here brings us to the airways, which is where the action occurs with respiratory viruses. And when you cough or you sneeze, you're going to produce in the air a whole collection of particles from droplets of liquids from the liquids lining the mucosa, which include very large droplets that follow a ballistic trajectory and fall quickly on the ground, and a very large spectrum of size of particles all the way down to 1 micron or less that are going to remain suspended in the air for a time that depends on their size. If you're infected with a respiratory virus, say the COVID virus, these viruses, although they're very small, they're not expelled as naked viruses. They're expelled as part of these particles. They're enclosed in these particles that although the particles are very small, they're much larger than the virus itself. And so the particles are exposed in that. And so when you are when someone infected with COVID is coughing or sneezing, they're putting out large droplet, which may infect you. These large droplets may instead fall on the ground or surfaces, contribute to the contamination of the environment, and you may have issues with contamination of the hand and so forth. And you have aerosol-sized droplets, which are infectious, obviously, at close proximity, but under certain circumstances can cause infection at a larger distance. Now, interestingly enough, in addition to coughing and sneezing, if you look at normal activities such as breathing or talking, these also produce particles, mostly aerosol size. You produce very little large droplet when you just are breathing in and out or when you're just talking. And this is very important to remember if you think about the importance that we keep hearing about how asymptomatic people infected with COVID can transmit the disease. How can they do that if not by aerosol? Because when you're asymptomatic, you don't cough and you don't sneeze. And so you don't put out much large droplet. You do put out aerosol, however. This is just a very technical slide that just document the idea that some aerosol-sized particles will remain lingering in the air for a very long time, depending on their size. Okay, this is the settling time in still air, but of course in practice the air is never still. There are always air current, thermal mixing, which kind of steer the particles in the air, and so aerosol particle can remain in the air for. So these particles that we think of are small spheres, like small marbles, and the dimension that we're giving is just the diameter of the sphere. Okay, and well, micron is the abbreviation of micrometer, and you have 1 million micrometer in a meter. So that gives you a little bit of the dimension. So these are particles that are typically not visible by naked eye in the domain of 1 to 10 micron. You need a microscope to see that. So we used to concentrate on the smaller micron, smaller size of 10 microns or less to talk about aerosol. We now understand that in fact, larger particle up to probably 100 micron can be carried away by an air jet, such as the air jet that are produced when you cough or when you sneeze or even when you talk. And these particle will be carried by the jet in distance that measures several meters beyond the mythical 2 meters that we keep hearing about before exiting the air jet and living their life as an aerosol depending on their size. And so we are now including under the term of aerosol particles that used to be larger than the previous definition, which was restricted to 10 micron or less. Of course, 10 micron or less, they will hang in the air much longer. But the key thing here is that these particles can be carried by an air current. And as such, they can follow an air current to go around the edge of a surgical mask. This is a point that has importance for protection against. So these are just two papers that were published a long time ago that want to illustrate the point is that we've been talking about aerosol transmission of respiratory viruses for a very, very long time, especially about viruses that can cause pandemic. And we have known that the SARS coronavirus, which caused the SARS outbreak in 2003, including in Toronto, could be transmitted by aerosol-sized particle, and the same is true of the MERS coronaviruses. So two emerging coronaviruses that cause very serious human disease that can be transmitted by aerosol. This should have been ringing a very loud alarm bell right from the beginning of the current pandemic. So there has been by now several studies that have documented that if you collect an aerosol sample from the air in the room of a patient with COVID, you can detect in these aerosol sample the COVID coronavirus. Okay, there are now too many of these studies to list them all in a single slide. I've just put some of the earliest and most prestigious. This was well established. The objection that was made to that early on was that, yeah, you've detected the virus by molecular method, but you have not demonstrated that the virus was still infectious, was still capable of causing an infection. And this is not as good an objection as you would think, because technically, it's not as easy to culture viruses as it is to culture bacteria. Okay, and a consequence of that is that it's not very sensitive to detect virus by culture as opposed to do it by molecular methods. It takes a lot of virus to be detected by culture method. And on top of that, the very action of collecting aerosols with the type of collectors that are required will damage the virus particle and damage the infectivity. So if you can detect them by molecular method, by PCR, but you fail to culture them, does not provide an absolute reassurance because the threshold of sensitivity are so different. In spite of all this, there has been by now two studies, next slide please, and I'm showing you one of them here, in which they have succeeded in not only detecting virus in aerosol sample from a hospital room using molecular method, but they have succeeded in cultivating the virus in cell culture from this sample, which shows that in fact, the virus was still infectious in these aerosol sample, and which considerably reinforced the contention that aerosol transmission is also a mode of transmission that's occurring with the SARS coronavirus, with the COVID coronavirus. So this is another, it's a very fun, very interesting experiment that has been done by the virology group at the Erasmus University, transmission of a respiratory virus by aerosols between ferrets. So you have the donor ferrets on the bottom cage, and you have airflow at low velocity that goes to the cage, must ascend a tube of a little bit more than 1 meter length before entering the cage on top of it. And so only aerosol-sized particle could be carried away like this. A large droplet following a ballistic trajectory would not be able to negotiate this curve going upwards. and they could demonstrated transmission of the influenza A virus from ferret to ferret, of the SARS coronavirus from ferret to ferret, and of the COVID coronavirus from ferret to ferret. So this is an experiment of animal transmission by aerosol. Okay. And so the last slide, I just want to outline briefly what is to be done about transmission of COVID. If you want to slow or abrogate the transmission of the virus, you've got to act on all three modes of transmission. So by all means, and hygiene, by all means, cleaning surfaces. You want to have social distanciation. 2 meters is better than nothing, but in some circumstances, you may need a longer distance than that. Wearing a mask by the general public is a great idea because it prevents you from emitting particles both in the large droplet range and in the aerosol range. It's not 100%, but it diminishes considerably the amount of particles put out by the wearer. And it also provides some protection against the particle. However, if you are talking about healthcare workers that must prodigalate care to infected patients at close range for a prolonged period of time, you need to have better protection than just a surgical mask, and chiefly because of providing a seal around the airways so that the aerosols, which can follow air current, cannot go around the edge of the mask. So you're talking about N95 of higher protection. Also, very importantly, these aerosols that are suspended in the air of a room, they can be removed by proper ventilation. And so that's the importance of ventilation, is that if with proper ventilation, you will remove this particle in the air. Think again about a cigarette smoker. At close range, you're exposed to a lot of cigarette smoke. You're less exposed at a greater distance. And if there's good ventilation in the room at a greater distance, you won't be exposed to cigarettes.
So let's, Stéphane, perhaps introduce yourself and your background and take it from there.
So hi, I'm Stéphane Bilodeau, as Alex just mentioned. So I'm a professional engineer. I have a PhD in mechanical engineer. More specifically, I've made my doctoral study in ventilation, controlling contaminants and humidity inside the buildings, essentially. So that's from the start of my career, I've worked on ventilation. So today I will talk about essentially why and how we can and we need to improve ventilation to reduce the risk of exposure, especially in LTC, by the way, with the capacity of aerosols to contaminate, as Ray just explained, even people which are in these settings, even with the regular surgical mask. So, and I'll talk about more specific items as well. So I've been asked for some items on purifiers and stuff like that. So I will address that later on in the presentation. So I'll try to work this out correctly. So it looks like it's changing. So you're seeing right now a slide that Ray presented a bit differently from Moraska and colleagues. I just want to highlight the fact that they were also addressing the ventilation and the air cleaning aspects. So, and not only them, so the UK Chartered Institution of Buildings Engineers, Service Engineers, have done something similar. You see that on the left, the upper left diagram is not exactly the same, but talking about the same things. And it's because the way to control the amount of aerosol in a building, there are different ways, but ventilation and air cleaning are definitely two important ways to do that. Mariska also added in the graphs things like other things like UV lamp and stuff like that, but we'll see later on, and portable air cleaners, and we'll see later on what it's all about. This is in fact, we're interested in aerosols, especially because, as Ray pointed out really clearly, so the virus is able to survive for a long period of time in small droplets, micro droplets that we call aerosol, essentially. So it's a size thing. So you see the virus itself is really small, but it survives in an environment of essentially water, salt, and what exactly Ray explained earlier. So this is the first item, and the way the virus is able to reach out for other hosts, essentially, is to spread. And not only that, directly spread caused by discussions, talking, coughing, singing, etc. So in any type of internal setting, that's something you see often. And not only that, it's able to resuspend itself. So these small droplets are slowly falling in a building. They can travel for a long distance, by the way. So you see, I've put some technical drawings on the right. Doesn't necessarily need to go very in details, but what you need to recall, it's well beyond the 2 meters that we're typically hearing. So it's well beyond that for smaller micro droplets, so smaller aerosols essentially. And the smaller they are, the longer the distance they can travel. And not only that, they can also they're able to carry a survivable virus. So there is a viral load in these aerosols that are flowing. So the objective of ventilation is essentially to play on the dilution part of it. So we need with ventilation to reduce the load, the overall load in a setting, in an internal. Oops, okay, that's fine. I was losing the. So there are many examples of studies that we're talking about this, specifically in long-term care and hospitals as well. So you see on the right, the bottom right, that was a study that was done and was extensively studying. We were extensively studying the level of aerosols in 2 rooms that were just beside each other. That was a hospital, but you can clearly understand that in an LTC that would be the same thing. In other examples on the upper left, sorry, you have examples that came from study in Nebraska facilities or in Singapore as well, seeing the same thing. What I want to highlight here as well is what you see on the bottom left. So the survival capacity of the virus RNAs in aerosol is quite long. So the half-life, it's a bit like with nuclear things. So the half-life of the survivability of the virus is calculated in half-life. So it's halfway through the end of its life, if I simplify it. So the half-life of a virus can range from 1 hour, less if it's cleaned up indeed, but in aerosols from 1 hour to 16 hours in specific environment. So we're no more talking about seconds or just a few minutes. It can be there for a long time when the conditions are there. So there are complex calculations, as you see, that we can use to evaluate the time, but we should not stop at just a couple seconds. It's not like it's just a droplet that would fall. Okay, you see the bigger droplets, what they're doing is a bit like a ballistic missile. So they're leaving the mouth and they're falling directly just in front of you. So 1 meter, 1.5 meters. But that's not those droplets that we're more concerned of. It's the aerosol, so the smaller one. Ray just explained the difference in the sizing, but those who are in the 20, 10 microns, 5 microns, and even below that, those are the most dangerous because they can be floating, gliding in the air for a long period of time and long distances, as I said. And that has been measured in the examples I was just showing here. But just trying to get back on the control. It looks like it's leaving sometimes. Okay. So what we need to do to remove the virus from the air. So there are many things, inactivation, settling, so meaning we're waiting for the virus to fall down. That's not what we want in an LTC. We want to catch them up before there's, in fact, before the hours where they would be surviving in aerosols. So ventilation is the key then. So that's in the middle of this slide, you see that's the best way to do that quickly with aerosols. And there are many reasons. You can also control the humidity. You know, the viruses are surviving more longer in an environment which is more humid, but the aerosols are getting smaller and smaller when it's drier. So this is a kind of mixed situation. So if you have an environment which is too dry, so the aerosols will get smaller. The consequence of that is they will float or glide in the air for a longer period of time and long distance. So if you're not controlling your humidity in a building, what happens is you kind of boost the capacity of aerosols to last for a longer period of time. So that's another thing you need to do. So ventilation can do that. There are some easy things to do first. So it's on the small table on the left, essentially increasing ventilation where it's possible. So when you have ventilation system, sorry, which is not at its limit, you can just increase the number of liter per second. That's a no-brainer essentially, but that's an easy thing. Second thing, if it's not possible, you're already at the maximum, so you optimize the control. So you have areas in a building, an LTC, for example, rooms which are occupied versus rooms which are not. So rather than sending air everywhere the same way, you control the air where the occupation is there and important. So you have fresh air. I'm talking about fresh air here. It's important to get the difference between just recirculation of the air, which is not a good thing when you have virus, and fresh air. So you're coming with clean, fresh air, and you're optimizing that with control as well. You can also invest in CO2 monitoring. That's not a really expensive thing. That's an easy thing to put in different environment. And you can monitor with the CO2 the amount of occupation of a space. So if it's a room, that's easy, you know you have it's occupied or not. But if it's a kind of another area where there is sometimes people and there's other times where there is not. So you can also use the CO2 monitoring system to make sure that you push the air, if you're limited, where it's absolutely needed. You also can think, and it's after having done the rest I've just mentioned, you can think of HEPA filters, so filtering, purification of the air sometimes. So that's another thing that can be done, but not necessarily the first thing, and I will explain that in a couple of slides. And finally, the last resort, but still efficient, it's opening windows. It's true that in Canada, opening windows some period of years not really a good thing, but on the aerosol control side, it's always a good thing to open windows. So when possible, that's better than doing nothing. The HEPA filters, so the purifiers or air cleaners, there are different names with that, are essentially a good thing if there is some if there are some conditions in place. First, they need to have proper filters. So HEPA filters are better. So we in engineering, we're also talking about MERV 13, MERV 16, and better. HEPA is essentially that's a minimum to make sure that you can collect, I would say, if you can get these aerosols, which are really tiny, really small. So those filters are able to get these really small particles, I would say. If the filter if the mesh is too wide, then they will just go through it, and that's not what you want. So good filters, they need to be cleaned correctly. And that's indeed like for any filters anyway. Even in your car, you have filters. If they're not clean, you have an issue. So it's the same thing in an environment with people, and even worse if there is a virus, which implies a virus. So you see on this graph, that you don't necessarily see, it's quite small, but I want to highlight the impact of a filter just on a purifier, just for you to understand what's the kind of things we're talking about. So on the right side, you see all the curves which are stick together essentially. That's for a big room with a specific HEPA filter. And on the left side, the other one, it's the same filter, the same HEPA filter, but in a smaller room, 10 times smaller. So what it shows is the amount or the percentage of persons which might be infected in 2 hours while they are in a room which has the presence of a virus in the aerosol. So you see, if there is no ventilation at all, no filter at all, so you're at the bottom blue line, not the bottom, the upper blue line. If you're at the bottom blue line, it's the filter with its maximum capacity, so the maximum number of cubic feet per minute or liter per second. And that's the best thing you can get from a filter. So you're starting from 8% of the persons after 2 hours that could be infected, contrary to, in fact, in opposition to 2% in this test setting. So for the small room, for the big room, the difference is much smaller. So the filter impact on a small environment, it's a bit less, and substantially less, I should say, depending on the size. That's 10 times difference. That's quite the difference. But if it's a bit larger, you'll already see some differences. So it's 1.1% contrary to 1.8%. So it's still relevant, but the biggest impact is for small room with no ventilation. That's what I wanted to highlight here. It's recommended by CDC as a helping apparatus. Same thing for the EPA in the US. And this very graph is coming from the UK. So in UK as well, they're recommending it in specific applications. And I just explained one of them. So that's my last slide. So I will finish within the plus a minute or two within the range we have wanted to do the presentation. So essentially, engineers can be involved as soon as the simple and early things cannot be achieved. So for example, just increasing the ventilation or just adding some simple CO2 monitoring to validate the occupation of a space, or simple things like opening windows. Indeed, you don't need an engineer to decide to open the windows. But as soon as you have a more severe more severe conditions in the settings, you need to have professionals that are helping to optimize, for example, the ventilation system, or even to add a new one. If it's to be added, indeed, that's required to have an engineer working on this on the design. So there are, I just want you to get that there are some simple things that need to be looked at really early. They are listed in the green box, and then there are more complex things that might need professionals to be involved. And in LTC, they can do that together.
So the next very important one, and I feel so so glad that we have Simon Smith with us. Maybe Simon, introduce yourself.
Simon Smith, and thank you very much for the introduction. It's very generous. I guess as a bit of background, I did doctoral work in actual filter materials, and then spent a career, which I've just retired from just over a year ago, in the design of respirator filters for various applications for a major manufacturer. As part of that, I also became involved in standards work with the Canadian Standards Association and with the International Organization for Standardization. So I'm involved in some committees there where we are developing performance standards for respirators and also looking at selection guidance. So that's a bit of background. I'm afraid I feel, compared with other presentations, this is almost skimming a stone over the top of the area. So I'll apologize for that, and I have some follow-up slides as well I can provide with more information. Talking on personal protective equipment, PPE, some diagrams here from CDC, and we can see that what's important, of course, is skin protection through use of gloves and body clothing, eye protection, and there are goggles and visors of different types to assist with that, to protect again against airborne contamination, which may interfere with the eyes. But the one most people focus on is respiratory protection. But the overall definition of PPE is addressing basically the protection of the individual from a range of different hazards, one of which is biological. But the rest of this is going to focus on respiratory, as that's, of course, the one that comes up when we're talking aerosols, and the one about which there's probably been, again, very superficial, but the thing to remember when it comes to talking about respiratory protection, you can think of it in terms of 3 Fs. As you see there, filtration, fit, and function. Sometimes in information from the government, say, or other articles, you may find there's just focus on the filtration capability, as if that implies that that is what gives you protection. It's not. It's one of 3 components. If you're talking some kind of system for protecting against airborne particles going into the mouth and nose, you need all of these. Filtration being, of course, the ability of the material to remove material passing through it. The fit, ensuring that there is not leakage around the periphery of the item when it's worn on the face. And function, meaning that can you use the product when it's worn? If something impedes airflow too much that it's very hard to breathe through, you have to take it off to draw a decent breath, or it impedes your ability to communicate. It's overall, when you are dealing with that, you are losing protection. So you need a balance of these 3 features in order to get good protection from the airborne contamination. And there's some terminology there that you'll see in terms of these that I can explain more later on if need be. But you must have a balance of these and all of them present to get good protection, not just one of them. I'll try to go to the next slide. we are familiar with the issues of what people call masks, basically, and that has been applied very broadly. We generally mean actually 3 different kinds of things, as you see there. The simple face coverings that people are now being encouraged to wear at all times. They don't have any requirements set up to how well they perform. They don't seal that well to the face and really comprise any kind of filtration material. So the overall protection is modest at best. It does provide this aspect of source control, stops material being expelled from the mouth, but is not really that effective a filter at protecting the wearer from what's in the air. In the medical field, surgical masks have been widely used, and unfortunately, sometimes more credence is given to their capabilities than is really justified. They don't seal well to the face either, so there's large gaps around the sides. The material they're made from actually does have some filtering capability, and there are tests set up to verify this. But again, they don't really provide what would one call respiratory protection because they do not have that good seal to the face. And we get to the higher level being the approved respirator, the so-called filtering face piece that is probably the most familiar that's seen. We've just had guidance over the course of the summer that you can use a surgical mask in a hospital generally, but when it's an aerosol generated procedure, which has various definitions, you need something like an approved respirator, the N95 type or others. These are governed by standards and regulations, which I'll get into in a minute. So there's actually good assurance that they actually work. They do have a good seal to the face, and that's something that is tested when they're selected first and then used every time. And there's specific requirements for filtration materials to ensure they meet a very high standard of capability. So they're the best in terms of protection. And when it comes to considering aerosols, they are really the minimum level you start with, because the other ones, as I said, do not seal well and therefore do allow material around. I did actually it was almost a bit of fun, but I did technically try to fit test a surgical mask using a recognized method. This is actually back in 2008, and showed through demonstration that it was actually about as good as having your hand over your mouth for protection purposes. So it is something that is not ideal. Unfortunately, shortages have driven decisions, and sometimes entrenched I guess medical knowledge, the way infection control has been taught, has said that that is good enough. But in fact, it's generally recognized that the N95 type, the filtering face piece, is the minimum level of protection that would be acceptable. On to the next slide. Sorry, it's changing slowly, but when you look at the spectrum of the range of respiratory protective equipment that is available, that has been developed over the years, the filtering face piece is in fact the least of the level of protection in that set, and you have available equipment that provides higher levels of protection, right from the elastomeric masks of different kinds to powered air respirators that actually have a blower drawing air through a filter and feeding it to the head top. The highest level being self-contained breathing apparatus does not really apply in healthcare, but of course is what is used in firefighting. And for each of those, as you see in the table below, you have options in terms of the level of protection. But generally, for the higher level of protection, you start to pay a price in terms of the duration you can use them, the logistics and comfort of wearing them, and of course of the cost of them as well. So that's sometimes been a driver in decisions, but yeah, you can see there are other options. And what this also indicates is that in healthcare, you could be using other types of respirator than just the filtering face piece. And gets quite adequate, in fact, better protection than the filtering face piece. And so this has an impact when we're considering shortages, that there are other sources of supply that could be used. And I think there's now recognition coming around to that as well, which is fortunate. And in the interest of time, I'll run through a couple of slides quickly, but the issues around standards and certification for respirators, it is not just a lucky chance that they work. There's actually a very strong system for defining performance standards and certifying the products to those standards by recognized, sometimes governmental or other authorities, to ensure that the respirators actually perform as they are intended to and meet set levels of performance. This is through documents and through structures. We in Canada have for a long time used the US system. In fact, you'll hear about NIOSH N95 and so on in terms of a type of respirator. We are actually in the process now of developing our own requirements for performance in Canada. But one thing to mention is in the green box there is, in fact, overall, healthcare has not been a specialized industry, the same standards for the needs for respiratory protection apply in healthcare as in general industry. So again, it's quite feasible to use the same criteria and industrial respirators in healthcare. There's been research that shows that biological particles have no real difference when it comes to filtering through a respirator than an inert, say, dust or maybe metal particle. And so you have the ability for, as I said, a broad range of products to be used in healthcare potentially, rather than just needing to be specialized. The only separate requirement is that there are splash requirements for some items in healthcare that most industrial respirators have not been tested for, but it doesn't mean that they don't meet them. The other aspect around use of respirators comes to the selection for, the criteria for selection. So slide is changing slowly again. Sorry, it seems to have jammed. As well as ensuring that the product meets capabilities, there's also the need to select the right kind of product according to the hazard that is faced. And again, there are standards in Canada for that. There's actually regulation that says this must be done according to a set program, and a Canadian standard actually defines a method for overall having an entire respirator program in an organization where it's needed, and then the criteria within that for selecting the right kind of respirator for the job. As you see, there's flowcharts and guidance in here, and I can talk about that at length if of interest. So there is a very comprehensive system, not just for ensuring the products work, but ensuring you pick the right ones. And when you have done that with fit testing and other aspects of use, you ensure that they are maintained properly and providing the highest level of protection in the circumstances. Unfortunately, with this standard, it was the first in the world, as it says, to define a method for selecting for biological aerosols, but we haven't seen a lot about it, a lot of reference to it in any government guidance. It would be nice if that were done, because this was actually based on some of the principles out of the Campbell Commission when this was developed, and it does follow the precautionary principle and the aspects that you don't make assumptions about the lack of aerosol transmission by, for instance, with the availability of product, the concerns over the filtering face piece, there are options for industrial respirators to be used because they are better than, in fact, in most cases, the filtering face piece N95 type. There are industrial versions of those, as well as you see, half and full face elastomeric respirators, as they're called, reusable types. Some hospitals have been using those for years in the US and in Europe. And at a higher level is the powered air purifying respirator type I mentioned, where you have a belt-mounted blower in some cases. You also have neck-mounted and head-mounted blower versions that actually draw air through a filter, feed it out at elevated flow, so it flows out from the wearer, and that air outflow provides a level of protection that's higher than having just a seal against your face. So they are used in some circumstances where you need higher protection. And also, of course, if people have beards and such and can't be fitted properly with a regular respirator. I mentioned the Canadian standard, we talked about that in this issue. As Kevin mentioned, that it does bring in ventilation. We have guidance from various authorities that say for an aerosol generating procedure, you use the filtering face piece N95. Where the Canadian standard goes with that is actually the one you would use in the highest level of ventilation. But if you get to a situation, say not in a surgical suite, but you're working perhaps with a patient in a corridor because it's got so crowded in the hospital, where the ventilation is much poorer, the Canadian standard would recommend going to a higher level of the two other types you see here as necessary, because in effect, the aerosol is not going to be dispersed. It's not going to be moved away by ventilation as fast in the corridor, and therefore you need a higher level against them.
Let's finish with Dorothy.
So thanks, Alec, and thanks for including me in this. So my name is Dorothy Wigmore. I call myself an occupational health specialist because I not only have a degree in occupational hygiene from the UK, but I've got another degree related to ergonomics and things to do with stress from the US. And I've done a lot of education and writing. I said something earlier about having been a CUP president. I actually worked for the Globe and Mail at one point for a little while, not very long, but. And so what I want to talk about is something that I've been ranting about a lot during this pandemic, which is cleaning and disinfecting. I want to talk about the hazards and what some people are calling hygiene theater, and how less is actually more in terms of our health for this occasion. So I just want to make sure that we're all on the same page when it comes to knowing the difference between cleaning, sanitizing, and disinfecting. And so the basic thing here is that cleaners remove dirt. And you're talking about soap or detergent. And if people are going to go on further and disinfect or sanitize, they actually have to clean. So sanitizing actually deals with bacteria and removing it from surfaces, and it's not nearly as effective. It's not as effective as disinfecting. Disinfecting destroys most infectious germs, including viruses, but it doesn't have any effect on dirt. So all the people you're seeing in the grocery stores that are spraying a conveyor belt and wiping it off, even if they're using the so-called 2-in-1, aren't doing a damn thing to get rid of any viruses, because you have to do it twice. So they have to be left on for specific amounts of time. They have to be specifically diluted. And one important thing in terms of workplaces to know is that Health Canada registers these as drugs. So they're not required to have data sheets or labels. Now, there are exceptions in terms of some provincial legislation. So these days we're hearing a lot about just clean and disinfect. And I've got a little quote up there from a clip from the Health Canada website. But we know historically that disinfectants have been misused and overused. They're often prescribed by public health and infectious disease to say that they're not thinking about what else could be done. They're not thinking about the hazards. And in this pandemic, there's all kinds of calls to poison control centers. They're going through the roof in both Canada and the States. And there are these false claims about foggers. So this is something from St. Michael's School in Toronto, bragging about this fogging machine that they're using, which probably doesn't really do anything. So I want to be clear that we've known for a long time about the hazards of cleaning and disinfecting products. In the short term, there's a variety of things affecting the eyes, the skin. People might get nosebleeds, a sore throat. But we also know that they have long-term effects, and particularly asthma is one of the things that people worry about. They're both in terms of the products causing people to develop it and triggering attacks. But depending on the ingredients, there's everything from harm to the brain, the kidneys, the liver. There's endocrine disruptors, there's carcinogens, and things that cause cardiovascular problems. And this is summarized in a toolkit I worked on that I can tell you more about. So I just focusing on respiratory diseases. There's a study out in last year that looks at the different kinds of things, the ingredients that are causing problems, particularly respiratory disease. The thing that's important here is that it's not just affecting the people that are applying the stuff. It's people around them, and that more than cleaning staff are actually using these kinds of products. So we're talking about healthcare workers, we're talking about sports folks, teachers, chefs, kitchen workers, etc. So the one ingredient that is really ubiquitous and that is just in so many of the products I see these days is something called quats, or quaternary ammonium compounds. And if you're looking for them, you want to look for benzyl ammonium or chloride. They're all EPA and Health Canada approved, but this is a graphic showing the wide range of effects that they can have. And it ranges from cardiovascular to reproductive, DNA damage, memory effects, that kind of thing. Two of the really common kinds of products you've probably seen contain them. So they're in cleaning products, disinfectants, and a bunch of other things. And other problems with them include these kinds of things. They affect antimicrobial resistance. They don't work when they're sprayed in the air. They can stick or bind to cleaning cloths. They build up in sewage sludge, and they often need to be rinsed off. And in fact, there's such a concern that the Biomonitoring Scientific Guidance Panel in California in March decided that all quats are a designated chemical, and that they are going to be part of their biomonitoring program because of the health effects. And the place that I found this out from was a trade journal from the Chemical and Engineering News. So even the industry itself is starting to pay attention to these kinds of chemicals. And the other aspect to this is not only are there hazards, but this is probably a waste of time. I don't know how many of you saw the article from The Atlantic by Derek Thompson that talked about, that used the term hygiene theater. There have been stories, this guy, Dr. Emmanuel Goldman has been interviewed, all kinds of places. This is a quote from something that he talked to CBC about, saying there's not even a significant risk to, or a measurable risk to the virus being found on surfaces, the virus that's going to, in a form that's actually going to harm people. And so that he's saying that as CDC and others are saying, that so-called contact transmission is really not a major route.
Sorry.
So the question that I ask, sorry folks, with the green chemistry lens is it necessary to use this stuff? And the answer is not often in this pandemic, sorry. And if you do, there are options. There are these environmentally preferable products that are independently certified. Now, the ones that I refer people to have the labels from Cradle to Cradle, Green Seal, and Safer Choice, which is an EPA logo certification. Eco Logo allows quats, so I'm not recommending them. There are also checklists from the Toxic Use Reduction Institute and some other places. And this toolkit that I worked on with a couple of other people 5 years ago that goes through a whole thing about how to do what we call informed substitution. If you're going to actually use these kinds of chemicals, then let's look for the least toxic ones. There are other options like steam vapor devices. These are superheated steam, don't use chemicals. And as Jason from Turi pointed out, that EPA is in the process of probably saying that these are useful devices. But the question I want to raise is, what about soap? Soap and water disables this virus. And we know that microfiber cloths are very good at removing viruses, bacteria, and dirt all at the same time. And so when you combine that, the question is, if the CDC says on soft surfaces, which is where disinfectants cannot be used, that you clean it with soap and water, if we're washing our hands with soap and water to get rid of the virus, and if we combine, as Turi has pointed out, and Jason is working on, that with cleaning and hand washing, we get almost the same level of disappearance or disabling of the virus as we get with disinfection. Why are we not using soap and water and microfiber materials except in the places where we know they're really sick folks? The studies that have been done that look at and Raymond talked a little bit about this, that the idea of viability of the virus, that's part of the issue I have with the contact surface stuff, not with the aerosol end of things. But my main point here is that we're making people sick when we're supposed to be protecting their health. And the public health and infectious disease folks really are not only ignoring aerosol transmission, but the evidence for contact transmission is so little. John Odek was only able to find one study in the world of an outbreak that relates to surface transmission, and it was happening in a food processing place where it was really cold and really dry. So again, as Alex said, I know this sounds a little bit like it's not quite what people are recommending, but I would suggest that we need to worry more about what's in the air than we do on what's on surfaces, and we don't have to be wasting our money on expensive distancing people when we could be using soap and water and things like microfiber materials.